Thank you everyone for joining us today. So I'm Veenesh from the orthopedic department. It's a great honor and privilege to moderate this session and to introduce our next speaker. So our next speaker is Dr. Chong Pan Pan. She's a senior lecturer at the orthopedic department here in University Malaya. She holds a Bachelor of Science degree with honors, Master of Sciences in Biochemistry, and a PhD in tissue engineering. Her research mainly focuses on osteoarthritis, stem cells, and extracellular vesicles for cartilage regeneration. She currently oversees the clinical service utilizing platelet derived extracellular vesicles for the treatment of musculoskeletal disorders such as osteoarthritis. And this service is offered both here in UM Medical Center as well as UM Specialist Center. She has got an extensive CV with multiple publications and Young Investigator Award. So today, her topic is acellular treatment for knee osteoarthritis, current evidence and future perspective. Dr. Chang Pan Pan?
Yeah, thank you, Dr. Veenesh. Let me share the screen first. So, morning, everyone. Chong Pan Pan. Today, I would like to share with you acellular therapy for knee OA osteoarthritis, current evidence and the future perspective. Basically, OA is characterized by the loss of articular cartilage, accompanied by the attempt repair of articular cartilage, remodeling and sclerosis of the subchondral bone, and osteophyte formation. Once the cartilage is damaged, it's very difficult to repair because cartilage does not contain blood vessel and nerve. The changes seen in early OA were age-related, not to the sole contributor to the development of this disease. Because OA may occur as a result of trauma, injury to the joint, subsequent to infections as a result of aging or genetic disposition. There is about more than 500 million people affected with the knee OA. Usually, they are more than 55 years old. And the traditional method to repair the knee OA, for example, physiotherapy, non-surgical treatments such as NSAID or PRP injections, they are short-term. They have the short-term efficacy and adverse effect. People have to go for the total knee replacement. They have to pay for a very expensive procedure, and this TKR implant only can last for 20 years. So as you can see here, the stage of knee OA can be divided to stage 1, 2, 3, 4. So when the patient at the late stage of the OA, they have to go for this total knee replacement. And this surgery will cost about 30,000 in government hospital and double up the price in the private hospital. So bear in mind that this implant only can last for 20 years. That's why our surgeon is not encourage the young patient to go for this one. So for your information, articular cartilage is the cartilage that can be found in our knee. It composed of about 70 to 80% of the fluid. So usually it's the water, and 20% of the cellular matrices, which are polycellular, extracellular, and only 1 to 2% chondrocyte, which is the cartilage cell. The traditional method for the cartilage regeneration technique, first the surgeon will debride the lesions, remove the cartilage, and then they will perform the microfracture, use the surgical tool to make the small hole at the subchondral bone so that can release the bone marrow, and then they will implant with the autologous chondrocyte. So, and then the latest technology, they will secret this autologous chondrocyte inside a scaffold as a carrier. So as we know, the traditional method, the ACT, will cause the donor site mobility because we have to harvest the cartilage from the non-defect area, for example, here. So that's why basically will cause the donor site mobility. That's why now so that the technology, people suggest to use this stem cell, mesenchymal stem cell, because MSC have the multi-potent differentiation, so it eventually it can differentiate, become a chondrocyte, and also the cartilage. So I think about 13 years ago, people really focused on the mesenchymal stem cell study, and the gold standard for us to isolate the MSC is from the bone marrow. So that time, actually, during my PhD, we managed to isolate the MSC from the peripheral blood. It's just from the normal blood. We can isolate the MSC instead of using the bone marrow, which is invasive. And moving on, we also compare, is it necessary for us to differentiate the stem cell, become a chondrocyte, then we perform the cartilage repair? So in fact, that is not necessary, because our data show that either you use the MSC or differentiated or chondrogenic MSC, they produce a superior healing when compared to untreated. So now instead of using the stem cell, people also ask, can we use the secretome that derived from the stem cell? We also have performed this systematic review. So as you can see here, this is cell, and this is the exosome. It's not cell-free agents. Both of them have the advantages and disadvantages. So basically, the cell-free, we no need to culture the cell. And for your information, when our patient come to our UMNC, most of them actually they are not afford to go for the stem cell treatment, because usually the stem cell treatment will cost the patient about at least 20,000 plus minus per treatment. And for the stem cell, we need to culture the cell about 1 week. But if you're using the cell-free, we can just immediately use it. Therefore, our research group, we developed this thing, autologous platelet-derived extracellular vesicle enriched product. So first thing is, what is platelet? Basically, platelet is come from the fragmented cell of the megakaryocyte. So the diameter of the platelet is about 2 to 3 micrometer. And the platelet only can survive about 8 to 12 days. So usually for the healthy patient, their normal platelet count is 150,000 to 450,000 platelet per microliter. And the usual functions for platelet include hematosis, thrombosis, maintenance, regulation of the vascular tone, inflammation, host defense, and tumor biology. So we also have published one article about how to prepare this PRP, platelet-rich plasma, and its derivative. So as you can see here, basically it starts from your tube, whether contain the anticoagulant or without the calcineurin or with. If you without, so you can get the final product. We call this one platelet-rich fibrinogen TRF. If you come with the anticoagulant, after your spin centrifugations, you get this platelet per plasma. So from after that you collected this one, you either activate to make the cell burst, become the platelet lysage, or you use different method, you concentrate, you get the platelet-rich growth factor, or you activate the platelet, you get the small nanosite molecule, we call it as a platelet-derived extracellular vesicle, PDV. So for today's presentation, I will just share with you our experience in this study, PEV. So basically, PEV is a subset of platelet-rich plasma, smaller in size. So as you can see here, the platelet size is about 2,000 to 3,000 nanometer. And the EV usually is about 100 to 800 nanometer, and also have the subgroup called exosome, even smaller, for 50 to 150 nanometer. So basically, we group it as a platelet-derived extracellular vesicle, in short form PEV. So all these PEV, they are very rich in growth factor, cytokine, chemokine, or nucleic acids, and organelle. And bear in mind that this is a heterogeneous pool. They are not something like a very pure homologous population. They are heterogeneous. So basically, this platelet inside containing this alpha granule, dense granule, and lysosome. But these two, actually, the number is quite low. So usually you focus on this alpha granule. So as you can see here, alpha granule containing a lot of different type of the growth factor. For example, this one, the factor X, all these things, the fibronectin, all these things. Okay. So what is the role of PV in OA? Basically, PV rich in, as I mentioned just now, cytokine, chemokine, immunomodulating molecule, and the growth factor. So it can promote the cartilage repair, while the secretion of growth factor stimulates the proliferation of joint cells, possibility interfere with the inflammatory pathway to mediate the anti-inflammatory and anti-catabolic effect. So my student, she have done some fundamental in vitro study. So first, we had to characterize the PV, the isolated PV. So as you can see here, our size of PV is about 80 to 500 nanometer particle. And also this PV it show the negative expression, show the positive expression for the EV markers, and it's also enhance the cell proliferation. So we culture the chondrocyte using this PV. As we know, when we perform the cell culture, usually we use the 10% FPS, beta serum. So we use this as compare, and then we use different concentrations. So sometimes doesn't mean higher concentration is better. So as you can see here, actually at day and night, the 10% provided is the better cell proliferation rate. This is the reason is when the PV is too concentrated in the small limited culture flask, actually all the particle UV already occupied the space. That's why the cell cannot keep on proliferate or regrow. So after we try different concentration, we notice that 10% PV is better. So compared with the normal standard, the 10% FPS, so it's about 6 times better, the cell proliferation rate. So this PV also having this anti-inflammatory effect. So as I mentioned just now, they can increase the cell proliferation of the chondrocyte. This is all the inflammatory factor, reduce the nitric oxide, reduce the MMP13. So it can preserve the chondrocyte phenotype and also promote the collagen 2. This is the matrix secreted by the chondrocyte. So promote the expression of collagen type 2 and SOX9. Then we also study about even there are small particles, do they contain any protein or not? So we have done this LCMS characterization. So we in total we identified about 754 identical protein. So we study about the PV itself, chondrocyte. So OA chondrocyte, we use the intradermal beta to induce the chondrocyte become osteoarthritic chondrocyte, and then we treated this chondrocyte with the PV, OA chondrocyte with the PV. Then we noticed that based on the gene oncology analysis, the protein that involved in the cell adhesion, cell migration, cellular protein localizations, and cytoskeleton organizations. So besides protein, we also study about the microRNA expression profiling. So as I said just now, we use this intradermal beta to induce this chondrocyte as a OA chondrocyte model, and we compare induced one, healthy one, and the OA we treated with this PV, and also the OA chondrocyte we treated with the PRP, because many people will compare how different the PV with the PRP. So we have done the comparisons. So as you can see here, this is the microarray expression analysis. So out of the 800, we notice that there is about 100 genes, 100 microRNA differently expressed when we compare with the healthy and OA chondrocyte. So what happened when we treated the OA chondrocyte with this PEV? That is about 128 microRNA differently expressed, and compared with PRP, 105. So what all this numbering telling us? As you can see here, when we treated the chondrocyte with the interleukin-1 beta, that means in OA condition, these microRNA, they are highly expressed. the function of this microRNA as listed, you can see here. So, but when we treated with the PV, suddenly from such a high expression, 180, become down-regulated. So compare PV with PRP, PV is better than PRP. So basically, this telling us PV can exhibit the superior anabolic activity compared to PRP. Then moving on, this is the down regulation. So during the OA conditions, so all these microRNA are inhibited. So when we treated with this PV, all these microRNA become increased. So as you can compare here, PV is still better than PRP. And this result show that this PV can promote the regulation of the anti-inflammatory microRNA than the PRP. So we have done the in vitro study. So now when we want to, actually we also have done the animal due to the time limitation. I'm not showing the animal study. So we just want to show you how can we provide the clinical service. So we have done all these things as you can see here. Now we are moving on to this clinical trial or clinical service. So our Nosera, we have this GMP lab. Is audited by the NPRA. So what is the procedure? When the patient, we have the inclusion-exclusion criteria. As you can see here, we encourage the patient, they are in the new OS stage 1 and 2. So another most important thing is the platelet count has to be normal platelet count. So that means the platelet count has to be 150,000 to 450,000 platelet per microliter. We just provide the process. We are not something like manipulate or produce the platelet. So garbage in, garbage out. If the patient doesn't have enough platelet, or let's say the platelet is unhealthy, we cannot do anything. That's why I highlight here, this is the most important inclusion criteria. And we also have do some pre-screening for some of the infection disease. So basically, we collect about 25 ml of the blood. Then our staff will process for the PV isolation. This will take about 18 minutes for us to process the PV. We already have patented the method for us to prepare this PV. And the final product we will keep in the syringe. So this is the packaging. So at the end, our surgeons can just intraarticular inject directly to the knee. So as I mentioned that focus for the patient are in the stage 1 and 2. Because as you can see, when they are in the late stage, they are already deformed, they know down the joints break. Actually, this PV cannot help. Okay. One of our medical officer also recruited 62 patients. So we have done some comparisons for PV treatment combined with the hyaluronic acid HA or HA alone. Control means the physiotherapy exercise. So we have the female and male, and usually OA patients mostly are majority female. And this is their severity of the breathing. As I mentioned, actually we prefer the patient in grade 1 and grade 2. But usually, as you know, patient if they can endure the pain, they won't come. So usually they come means they feel very pain already. So that's why usually our patient is mostly a late stage patient. But for the stage 4, we are not included in this study. So this is the 1, 2, 3 that we included. So we study about what happened after 1 month treatment and just with the single injections. As you can see here, pre-injection and post-injections. So the results show that post-injection is definitely is better than the untreated one. Okay. So this one, then we compare with different treatment. PV alone, PV plus HA, HA and control. So especially for the cruise pain, cruise quality of life, movement pain. So PV show a better clinical outcome. So as you can see here. So this is the user testimonial. 70 years old, female, left knee OA, 6 months post injection. My right knee is okay and better now after injection. Very good, can go market and exercise. So usually the OA patient, actually what they want is it's just really simple thing. 2 things only, no pain, and they can walk. So that's why, especially when the old auntie, they can perform their daily activity, they will feel very happy. This is some of the testimonial come from the patients. And so far, we have provided 157 treatment in our center. Actually, not only osteoarthritis, we also have plantar fasciitis, then this album, OCD harass as well. So we provide this PV treatment through our UMMC and UMSC. So this is the contact number, and we charge 1,500 per injections. So you can do some competitive analysis. Basically, PV, minimum invasive, immediate pain relief less than 1 week, long-term relief even can last more than 1 year, single injections, autologous blood source come from the patient own blood, less side effect, cost over benefit. Situation is low, and this one, the patient is high. This is HA, and this is PRP. So I just show you this picture. This is one of the company that sell this device to separate the PRP. So same, they will use about 25 ml of the blood, but they just do a simple centrifugation. Then they separate this so-called PRP. So as you can see here, the volume for PRP is about half size of this 25 ml. So I will say it's maybe about 12 ml. And usually the surgeon cannot inject all the 12 ml into the knee. They may just inject about 7 ml. So this PRP basically is a platelet poor plasma. It's not a concentrator. But what we have improved the technology is we process in our GMP lab, we patent this process. And then our final product in the stream. So the volume actually depends on the surgeon requirement. If let's say the surgeon say, I want 1 ml, we can just reduce to 1 ml. So some of the surgeons, they want to inject at the ankle joint there, even less, even can reduce less than 1 ml, 0.5 ml also can. Volume is not the matter. What we do is the platelet count, this PEV, or this platelet with the small derived EV, is how many EV particle containing in this one. It's not the volume, because we focus on the EV. Here, okay? So basically, this PV is monocyte, can promote chronocyte proliferations, maintain differentiated phenotype, can mitigate the inflammation, and also show better clinical outcome. So for this Acellular therapy for knee OA, what is the future perspective? First thing is standardization. A lot of people say, I use PRP for, I think you're all familiar with PRP. A lot of people say, this PRP is good, this PRP is not good. Why? Because they are not standardized the thing. So how they isolate, how they purify, whether they have done accreditation also very questionable because they want to save the cost. And what is the dosage? 1 injection, 2 injection, how they define this thing? Long-term efficacy, do they do any follow-up? And are they really understand the fundamental, the mechanism of action, as I showed just now? When you injected or when you treated the chondrocyte, what will happen? And regulatory approval, of course, we need the approval. This Acellular therapy actually is under biologic, under our NPRM, National Pharmaceutical Regulatory Agency, regulate. So all this treatment actually we need to get the approval from them. So the conclusion, this Acellular therapy actually is not only we just use it. We can just something like advance it using the scaffold, combined with the scaffold, for example, PLGA, the polymer, so that we can control release. How fast, how slow, how much that we want to release. Or we can engineer this particle, the unique exosome particle. For example, you encapsulate it with the microRNA, because we know certain microRNA or certain protein, certain growth factor, or even certain drug can help out in the knee osteoarthritis improvement. Then we can encapsulate this exosome with those things. So I would like to acknowledge all the people contribute for this project. Thank you.
Hi, thank you, Dr. Chong Pan Pan. Amazing. What an amazing talk. Very interesting. And looks like you're going to treat all osteoarthritis, and joint replacement surgeons like myself will be out of a job soon.
No,
Uh,
no, no. As I said, Dr. Veenesh, only early stage of OA. Final stage have to go for you.
Good, good, good. So I think we've got a couple of questions. So I think Dr. Lutfi has got a question for you. So you said, nice work, Dr. Chong Pan Pan. Any clinical studies comparing PEV and PRP?
Okay. For clinical study, we didn't do. So far I only have the in vitro study comparing. That means the lab comparison using the control site. For clinical, I don't have any result.
Okay, good. So you said about this PEV. So I mean, anywhere else in Malaysia other than here, do we provide the services? Because to be honest with you, when I came here, that's when I first heard of this PEV. Are they doing it anywhere else in Malaysia?
No, that's why we managed to patent the PED.
Okay, good. And so when you see a patient, who's the ideal patient? I mean, as you said earlier on, a lot of our patients they present late. I mean, especially in Malaysia, patients are very happy to just leave their knee if it's not too painful until it becomes very bad. For one question is how are we going to prevent this from patients from coming in late, uh, to come in early and see us? And the second thing is, what's your ideal patient?
Okay. First thing, the ideal patient is those in the early stage of OA, for example, stage 1 and 2. So actually, that's why awareness is very important. I hope the patient when they feel pain, they're supposed to go to the clinic to see the doctor, let the doctor to diagnose. So if let's say they are already diagnosed, they have the OA in the stage 1 and 2, it's better that they come from the treatment. They can just start with one injection first. So if they feel they can recover, they can stop. If cannot totally recover, they can go for a second and third injection. So it's better at the early treatment instead of wait until the late stage go for totally replacement.
Okay, good. So I've got a few more questions. So can PEV reverse stage 1 and stage 2 osteoarthritis?
Okay, the function for PEV actually is repair the cartilage. There will be two terms when we talk about the cartilage treatment. One is repair, one is regenerate. So what do you mean by repair? Repair means there is a small hole at the cartilage. So this PEV try to fill in or cover the defect because as I showed just now, this PEV can enhance the chondrocyte cell proliferation. So as long as they still have the cartilage with the cell, this PEV can enhance the cell proliferation to repair the certain cartilage defect. But when we talk about regenerate means if let's say your cartilage worn up, no more cartilage, you need a cell to differentiate become a chondrocyte. Then this is we have to go for the stem cell treatment. So usually the patient in the stage 1 and 2, they still have the cartilage. So that's why they need the PEV play as a role to enhance the cell proliferation, the host cell, the existing cartilage, to enhance the cell proliferation and also act as anti-inflammatory. That's why the patient will feel swelling. So when this V come in, anti-inflammation, then they can reduce the inflammation.
Okay, so just a final question, we got a couple of minutes more. Final question is, what is the side effect of this intervention, and what is the pharmacokinetics of this PEV?
Okay, basically I would say no side effect because basically this tablet is come from your own blood. As I said, I'm not modify anything. I didn't add in any extra thing. It's just the protocol for me to make the tablet from 2 to 3 micrometer become a smaller size. So basically, you just injected whatever thing that into your body. So if let's say your body feel cannot dissolve, cannot have any positive reaction, eventually you slowly dissolve by your body.
Okay. Uh, I think the same person asked, currently, how will you calculate the concentration?
Oh, it's the concentration, as I say, we are not focused on the volume. We focus on the particle count. That's why we use the NTA. So we count the NTA. And just for your information, some of you, if let's say you are not familiar with what is the nanotype, so a hair, just like our a hair, a piece of hair. So our hair, right, is equal to 100 micrometer, and this containing about 50 tablet. So containing 1,000 of EV. So imagine so small of our hair diameter containing 1,000 EV. So usually our treatment per treatment, we will inject 46 times 10 of power 12 EV particles into the patient.
Okay, Dr. Chong Pan Pan, it's amazing, very, very interesting talk and a lot to look forward to. So, guys, I'm sorry, we have to leave now because it's 9 o'clock already. So, obviously, if you've got any more questions, you can contact Dr. Chong Pan Pan through her email in the orthopedic department, Nostril, in University of Malaya. Thank you once again, everyone, and have a great day ahead of you. See you then.
Thank you.
Thank you, Dr. Chong Pan Pan.
Thank you.